APS to look at new and emerging apprenticeships within psychology and health.
Morning everyone, thank you very much for the invitation, delighted to be here. I'm Tracy Kinsley, I'm the Assessment and Awards Manager at the BPS, and Julie Davies is actually the Clinical Network Coordinator for North West Coast Clinical Network, NHS England and NHS Improvement. I'm sure Julie will introduce herself. I know I kind of have. Julie, are you on the call?
I am Tracy. Yes, good morning everyone. Yes, so I'm Julie Davies. I'm Clinical Network Coordinator for IAPT Workforce, working in the North West Coast Clinical Networks. We're part of NHS England and NHS Improvement. And my role is to support centralised recruitment, the development of centralised recruitment in Cheshire and Merseyside for trainee PWPs and trainee HITs. And also I'm supporting the development of an apprenticeship route, working with services. Okay.
Thanks, Julie, that's great. So as I say, it's wonderful to be here to talk to you about the new and emerging apprenticeship roles. Hope you find the presentation interesting and informative. I am slightly distracted today, just to let you know that we've got our first endpoint assessments happening today. And so at 10:25, I do have to hand a host over on Zoom. So if I'm slightly distracted around 10:25, that's why. So apologies for that in advance, but it is our first day of assessments today, which is wonderful and tremendous work gone into making that happen. So Julie and I are going to share the presentation between us. I'm going to kick off. Thought we'd give you a bit of an overview about apprenticeships in general and what the landscape looks like at the moment. So I'm sure that you all know that an apprenticeship is a job with training. There's a minimum of 30 hours. There is talk about reducing that down to 26, but it hasn't happened yet, along with all the other benefits of being a paid employee. You might be surprised to know that actually apprenticeships now are up to level 7. So the government in 2016 planned a huge reform agenda for apprenticeships because they wanted an alternative and complementary offer to degrees to raise the value and the reputation of apprenticeships, really, because it was very much traditional level 2s and 3s. So as part of that reform agenda, the payment for training for apprenticeships also changed. So you may be aware that an apprenticeship levy was introduced in March 2016. And for any employer with a wage bill of over £3 million, there's an automatic 0.5% levy that is deducted from in a tax format, and that is paid into the funding that then funds apprenticeship programmes. So quite significant for the NHS. So the NHS accounts for 2019-20 show that 45.1 billion was spent on salaries and wages, which actually means that the levy bill of 0.5% is around 225 million. So there's no average size of an NH trust, of course, but 600 million staff bill would incur a 3.2 million levy per year. So that's every year. If that's the bill for an NHS trust, they will be paying 3.2 million every year in a levy bill. The other thing that's happened is that employers, for the first time, have been able to become training providers, recognised as training providers. So that enables them to use their own levy pot and additional funding if they go over their levy pot to train apprentices. It can only be used to train apprentices at the moment. Again, there's talk of it perhaps going towards salary costs, but at the moment it is only for the training. So as you can imagine, the majority of NHS trusts have actually become employer providers, so that they can actually train and draw down that funding. And when they do that, they've got a choice to either train themselves and use that as evidence when they have the Ofsted inspection that they are training, but also they can subcontract to another organisation to deliver that training, and therefore a payment will take place. So the employer provider still draws down the funding, but then passes that on to a third party. Of course, there's always the traditional training providers as well, such as colleges and universities. They've also had to, universities have had to become training providers and apply for that as well. So a huge amount of applications taking place since 2016. So I've taken this chart from the NHS University Hospital Southampton because I thought it was a great example of the types of apprenticeships that are available and are being used within the NHS. You can see that they range from level 2 and 3, business admin, customer service, accounting, all kinds of different job roles. Within the NHS, and the two that we're missing, but I've put them on here, are the level 6, level 6 PWP and the clinical associate, which are the ones that Julie and I are going to talk to you a little bit about today. But I thought this was a really useful illustration of how some NHS trusts are using their levy pot to fund job roles, new and some existing job roles within the NHS. Okay, so some useful, excuse me, my phone's pinging, some useful websites just to show you how we have to manage the apprenticeships. So in order to actually write an apprenticeship standard, trailblazer groups were introduced, which are employer groups who are responsible for designing and writing all of the apprenticeship standards. The Institute for Apprenticeships of Technical Education, the IAPT, government body, is responsible for the quality of the apprenticeship standards and for approving apprenticeship standards. So if you did want to search these apprenticeship standards, the website is very, very easy to use. It's just a matter of going on to the IAPT website, clicking on apprenticeship standards and then typing in a keyword. You can also find an endpoint assessment organisation, of which BPS is the EPAO for PWPs. And you can have a look at the register of apprenticeship training providers. So if you're an employer provider, you would be on here. So the NHS trusts that have decided to become employer providers would be on this list of providers. And also there's a register of endpoint organisations and endpoint assessment organisations. And again, we've had to apply to be on that register. So there's quite a lot of documentation and things to understand even before we get to the delivery of the apprenticeships. So I've spoken a little bit about who funds apprenticeships. I'm going to say a little bit more and then I'm going to hand over to Julie, who will be able to talk to you about the HCPC, the HEE contributions. So in terms of the funding for the training, as I say, this comes from the government pot that is partly funded by the levy. And so that will just pay for the training. And I'm just going to hand over to Julie.
Thank you, Tracy. Yeah, so currently the core trainee PWP funding is provided on a basis of 60% central funding via Health Education England through NHS England and Improvement, and then also 40% is funded through the clinical commissioning groups. And that will be the same for the PWP apprenticeship that's going to be delivered locally too. Thanks, Tracy. Tracy, you're on mute.
Is that better? Can you hear me now? Excellent. So I thought it would be useful for you to understand how apprenticeships are also quality assured and who's interested in the quality of apprenticeships. So hopefully. So again, the IAPT, they monitor the quality assurance, and they have several publications available on their website. Including an EQA framework, which sets out readiness, monitoring and reporting. In addition to that, there are a huge amount of conditions that endpoint assessments organisations have to comply with. One set of conditions is from the IAPT, and it's called Conditions for Being on the Register of Endpoint Assessment Organisations. More recently, there's a requirement for all EPAOs, that's endpoint assessment organisations, to apply to become Ofqual recognised. And there's a whole raft of additional conditions and considerations for Ofqual. Ofsted actually inspect anyone who is an employer provider, depending on the levels and training provider, and the Office for Students is concerned with the high level and degree apprenticeship, so they will come and inspect employer providers and training providers against their framework. I'm just going to hand back over to Julie now.
Thanks, Tracy. It's a double act, isn't it? So just some context around the PWP, the IAPT PWP apprenticeship route. It presents an opportunity for a different route into PWP training, attracting people into a psychology role that may not have given some thought to that previously. It supports future workforce planning, so the ambitions of the NHS People Plan to upskill people and expand the workforce. And ultimately, in developing the workforce, we are supporting the ambitions of the long-term plan in meeting the referral and recovery standards and requirements. Thanks, Tracy. So why develop a PWP apprenticeship route? As I've mentioned, we need to meet the needs, increasing demand on IAPT services. We need the workforce to meet those demands. Many PWPs move on to the high intensity therapy role each year, so there's a constant churn. And services also report difficulty in recruiting qualified PWPs. Traditionally, the traditional PWP route attracts psychology graduates, so we're looking to widen that pool of talent to come into PWP training. There was a report done some time ago in 2017 about widening participation into PWP training, and that one of the recommendations there was to include an apprenticeship vocational route. With the apprenticeship, there is different funding, as Tracy has already alluded to, so it uses organisations' apprenticeship levy funding. So whilst currently the apprentice PWP would attract the salary support from HEE, employers can use their existing levy funding to support the educational part of the role. And there's also, with the apprenticeship route, there's an opportunity for services to work with training providers, to develop their own local requirements. And it is early days yet. The apprenticeship has only just been introduced, but there is that opportunity there. Next slide, Tracy. Thank you. So there was a national procurement exercise conducted earlier this year, and it resulted in the award of a national framework for PWPs to 7 training providers in England, and that included Liverpool John Moores University. So services can get in contact with any of those training providers to develop a programme. And those providers are offering a mix of online, blended approach, online approach. So it is possible that a university based elsewhere in the country could develop a programme with some of our local services. However, we have had some early conversations with Liverpool John Moores to develop the apprenticeship locally with some of our services. There is a small cohort planned for October, and we've had an initial meeting with some services who are really keen to develop the apprenticeship route. So the apprenticeship route is it's a level 6 non-degree qualification, and it leads to a certificate in psychology wellbeing practice. There's professional recognition, it's a regulated occupation, it's a minimum of 12-month training with an additional up to 3 months for the endpoint assessment, and Tracy will say a little bit more about the endpoint assessment in a moment. And there's been a lot of collaboration across regions to develop the PWP apprenticeship route, and I do have some slides from a webinar that was held on the 10th of May that are also really useful in conjunction with this presentation for those who need further information. I'm happy to share that, and that does include a presentation from Liverpool John Moores. Thank you, Tracy. Next slide. Thank you. So as mentioned, yes, there is a small cohort planned with Liverpool John Moores. The programme lead is Karen Ray, and I've just popped her email address on this slide, and I mentioned to Karen yesterday that I was doing this presentation, so if anybody does want to get in touch with Karen about the programme that they're developing, please do. So yes, we had an initial meeting with about 3 services who are really keen to develop the apprenticeship route. And from that meeting, we're developing some marketing material. I spoke to Karen yesterday, and that's in progress. Once we've got that marketing material, we can share that with services, and Liverpool will also post some information on their website. So that will enable services then to, we can develop a marketing strategy to target internally and externally the apprenticeship that they wish to deliver and support within their services. We've developed an outline job description and person specification. We need to sit down and just review that again to make sure it's fit for purpose and ensure that we do attract the wider pool of applicants that we want to for the apprenticeship route. And obviously we're having a first cohort. We would look to do some evaluation and gain some feedback from that first to inform future development of the role. Excuse me. And I just wanted to add here that the 3 universities across the Northwest, Liverpool, Central Lancashire and Manchester, already do have both a level 6 and level 7, an undergraduate and postgraduate route. And they do offer the opportunity for potential students to submit a portfolio of evidence of experience and academic ability. So the apprenticeship route offers another route, but there is already some work around attracting wider pool of students into PWP training. Thanks, Tracy.
Thanks, Julie. Really well timed as well, because I was able to sort out the Zoom meeting whilst you were talking. So great timing and a great double act, I'd say. So a little bit more about endpoint assessment. I can relax a little bit more now. So a little bit about endpoint assessment. So as we've already said, in terms of the on-training programme, all of that takes place before the endpoint assessment, and endpoint assessment is independent of the training programme. So once the training's complete, the apprentice enters something called Gateway, and that is the time that we, the endpoint assessment organisation, would look at all the evidence. So the employer provider or training provider needs to upload the evidence to us, and then we look at that, and then we will put them with the agreement of the provider forward for the endpoint assessment and all the organisation that goes alongside that. And then we apply for the certificate from the IAPT in addition to the other certificates that the apprentice will have gained through their training programme. As I say, the standards have been designed by occupational specialists through the Trailblazer group, and I just add one more comment, and in terms of the other rationale for introducing the apprenticeships is really sometimes a little bit of variability of kind of practice, and also standardisation of the assessment to make sure that assessment is covering all this knowledge, skills and behaviours required for the apprenticeship standard. So it is slightly different to the training and the courses that have gone before. So the PWP, as I said, on the IAPT website, you can download all of the information and documents that you need from there. And this is just showing you the psychological wellbeing practitioner, the occupational standard, which is a two-page summary. That's on the right-hand side. And then the actual assessment plan, which is, I think, is about 25 pages with all the criteria, everything that needs to happen within endpoint assessment. And that's kind of the rule book for when we're designing any assessments. In the PWP, there's actually two main assessment methods that are happening today. Actually, I've just let demonstration of practice station 2, the assessor in for their second session. So the demonstration of practice is split into two parts. Station 1, the patient-centred assessment, and Station 2, psychological intervention. And then there's a presentation of practice that the apprentice makes, all accompanied with questions and answers and judged against criteria set out in the assessment plan. The clinical associate in psychology, it is actually approved quite recently. We haven't applied to be an endpoint assessment organisation yet, but we will be, even though it is an integrated degree, which means that universities can assess if they want to themselves. However, we think that some universities will see the benefit in having independent assessment alongside anything that they plan to do themselves. And so we are actually planning to apply for the clinical associate quite soon. In addition to all the support that universities can help you with, and there's obviously lots and lots of support there, we also offer quite a lot of support for employed providers and training providers along the whole of the process of endpoint assessment, from registration, which is within the first 3 months of training, reservation to reserve all of the endpoint assessment dates, lots of support materials, what happens on the day of endpoint assessment, gateway information, results and surveys. So I'm sure you'd expect all of that support to be in place on that's a provider portal. We also have assessor portals, assessment instrument portals, and an internal qualification, internal quality assurance portal as well. But this one is the outward facing provider portal. We also have lots of guidance documents. Well, we have 3 main ones. This is one of them. This is the specification document, which really is kind of rewording and duplication of the assessment plan, but we try and lay it out so that it makes a little bit more sense and is as helpful as it can be for anyone involved with training and also for apprentices. We also, it's not on here, but we also have a venue requirements document, which is again a really useful document. It helps people to actually prepare for the EPA on the day and puts lots of checks in place for them just to make sure that they're going to be ready and the accommodation or the online facilities are appropriate. So we've covered an awful lot in this presentation and we have left some time for questions. There's a huge amount of reading on this. If anybody wants to have a look at any of those, all of the links are here on this last page before we move into questions. And just before I go on to that slide, Julia, I just wondered if there's anything you would like to add that you think that we haven't covered.
No, just to say, as I alluded to, there is some slides that I can share and an FAQ document from a webinar that was held in May that I think would be useful for the audience. So happy to send that to you, Polly, Claire.
Thank you. Thanks very much, Julie and Tracy. Really informative and very useful presentation, because I know that a lot of people have been hearing about apprenticeships for a long time, but on the ground it's quite difficult to understand exactly what they mean and the nuts and bolts of them. So particularly with the CAPS and the PWP roles coming online, this is very, very timely. So thank you. We've got the opportunity for questions from the audience, people that you may have questions or observations that you'd like to share whilst we've got Julie and Tracy with us. I've actually put in a couple of questions to kick us off, and then if others have them, please do put them in the chat box or raise your hand. So shall I kick off and just ask you my couple? And one was around third sector, smaller organisations that aren't large enough to pay the levy. For instance, often it can be third sector providers, often which are often used within IAPT services especially. Could you explain a bit about how they access the levy and how that works?
Yeah, so because they don't pay the levy and they won't have a digital account, it's absolutely no problem whatsoever. What they would need to do, unless they're an employer provider, and there are some very small organisations who are employer providers, if they're an employer provider, they will have access to the portal and they will be able to register their apprentices on that portal. If they haven't got that sort of employer provider status, they need to find a provider that they want to work with. So university, it could be another NHS trust, it could be, you know, an organisation within their contacts that are employer providers, and work with them to you know, see if the programme is fit for purpose for their needs and for the apprentices and the job role, of course, and then the provider will draw down that funding and deliver the training, so they shouldn't actually be a cost to the actual organisation.
Thank you. That's really helpful. My other question was, are there universities or education providers providing the apprenticeship as well as Liverpool John Moores at the moment across the Northwest?
The nearest one is Staffordshire University, so that obviously is relevant to some parts of the Northwest. So the slides that I have from this webinar on the 10th of May included a presentation from Liverpool, from Staffordshire, and because we were linking regionally across to North East, there was a presentation from Teesside as well. So that might be interesting for colleagues to see.
That'd be lovely. Thanks,
Okay.
Julie.
And also, just to let you know, the universities that have already contacted us and we're working actively with. So we've got a cohort of 60 already that are, some are sitting today. We've got 4 apprentices sitting today and 4 tomorrow. That's with Oxford Health. And they've got another in total 60 before the end of this year. Some are due in October, some are due in November, and they are recruiting for another, I think 1 or 2 cohorts for next year. And it's a 12-month programme, so we would see them coming through in 12 months' time. The other universities that we've been working with and talking to about their plans and the cohorts, and generally they're talking about a cohort between 20 and 30 on the apprenticeship sort of route, if you like. So we've been talking to Exeter, Leeds Beckett, Liverpool, John Moores, Oxford Health I've mentioned, and Staffordshire. So those are the universities we've been talking to date. And it's a good idea to contact the Endpoint Assessment organisation ourselves early on, because we know the requirements of the assessment, and we can talk to, we can't advise on how people train, of course that's not our job, but we can talk about how we've planned the assessments, how we've read the assessment plan, how we've made sense of the assessment plan, and also those documents like the specification document is a really nice document to be able to hand out to apprentices early doors, and even the venue and online requirements document, because it makes it very, very real. So with Oxford Health, we had a pre-meet with the apprentices because it was all going to be online, and also we've had individual online meetings with them just to test equipment, and it was really useful. We had an hour of apprentices asking all sorts of questions, and I think this is the benefit of having an independent assessment organisation. It makes it feel very, very real, and it makes it, you know, higher stakes really. Well, that's my perception. You know, they were obviously wanting to prepare as well as they could for an external assessment, and you know, it's almost viewing it like the A-levels, the GCSEs, that this is an assessment. You're not going to get feedback on the day. You're going to be assessed by experts, people who are in the field, and you know, you will be judged against those knowledge, skills and behaviours. And so yeah, so there's a lot of interest at the moment, and hopefully more.
Thank you. So really reassuring that there's rigour around the academic and the endpoint assessment. There aren't any other questions in the chat box at the moment, so at the risk of monopolising the conversation, I just wanted to ask you a couple of other questions. But oh, I can see Dale's hand has gone up. So before I ask another question, Dale, do you want to unmute and ask your question?
I've managed to unmute. Just saving your voice, Claire.
Mm-hmm.
Thanks ever so much, Julie and Tracy. That was really informative. There's a lot of information there, and having the slides would be really helpful to pick through and kind of understand, I guess, strategically how we can use these opportunities. I suppose it's in a way more obvious how the developments PWP wise would fit in and meet population need, and the idea of widening access is just a wonderful opportunity and not before time in terms of doing that, and it really does open the door for people who would be potentially fantastically suited to that role, but may not want to pursue or develop, or may do, but may be less likely to want to pursue or develop further education, further qualification. So that's great. The bit that I think I'm still trying to understand, there are a lot of roles which have arrived, and I think of filling a void in the environment. There's some gardening metaphor in the back of my mind that's not quite coming through, but the idea is that we know that the environment is fertile for new roles. There's a need for increase in psychological skills and expertise. But you know, we've got a couple of TAPS roles, we've got the new mental health wellbeing practitioner role, we've got the CAPS role. Now, my understanding of the CAPS role is it would need to be domain specific, so the course would need to be set up, whether it's for community mental health, whether it's for children and family, whatever it might be. Has any central work been done to kind of map the gaps in the terrain? and match them against the new developing roles, just to make sure, you know, I'm almost picturing a Venn diagram in terms of thinking we've got these recognised gaps in provision, an absence of psychological skills and expertise in these domains, and this is how the various new roles will complement each other. Or is there a risk of you know, I guess organically, good to go back to the garden, lots of stuff competing for the same space, basically?
Shall I try to answer that? Okay, so in terms of the bigger landscape, really the IAPT in terms of apprenticeships has got that responsibility, but I would agree with you, there's plenty of blooms in the garden, not only within health but all over. In fact, the number of apprenticeship standards has increased. I think there's around 650 different apprenticeship standards now, where we used to have around about 400. But it was all down to employer demand, and so trailblazers were put in place where they thought there was either a gap or variability or lack of standardisation, and it was the trailblazers' role to fill that gap with an apprenticeship. And the overarching kind of you know, horizon, the whole horizon, is really the responsibility of the Institute for Apprenticeship and Technical Education. The HEE would also potentially, you know, want to get involved with that, and I'm sure are informing the IAPT and involved. I'm only, you know, guessing that that's happening. But my colleague Claire Tilley, she works more on the development side. She isn't here today, but she would be able to talk to you more wider than I can on that wider landscape. So it might be worth picking that up with Claire. That's my understanding.
Thanks, Tracy. And certainly it sounds like that could be an invitation that we might extend to Claire for our next meeting. There's a sort of there's a conversation that's starting here around new roles, isn't there, and our understanding of them. And I know that issue of the mapping and the kind of matching and the overlap of new roles is a conversation that's coming up pretty frequently at the moment. Okay, so thanks, Dale. Thanks for that question. We've we've got 3 minutes just before we break for a short comfort break. So is there anybody else that would like to ask a final quick question? Anything that anybody needs to clarify, or anything you want to add, Tracy? I can see you.
I was just going to add that if it would be useful, the two developers that have developed all of the assessment instruments, alongside obviously me supporting and the BPS supporting, alongside the design of, you know, what it actually is operationally, we have two very, very experienced and knowledgeable developers, as you can imagine, that are actually taking the assessments today. And they're also going to be the IQAs, which is wonderful. I'm sure that they would be very, very happy to come to a future meeting and talk specifically about the content and how it's gone, and a reflection on, you know, the endpoint assessment process, and give their expert opinion, because obviously I know about endpoint assessment, but I'm not a PWP, and, you know, so if that is useful, we could certainly ask them to come along.
That sounds really helpful, Tracy. If you could provide me with the details of that, then we can look at that for a future programme. And the timing of it sounds quite important. I think you're right, this is the start of an initiative, and it will be really useful to come back at some point in the not too distant future to learn how it's going, and to also hear maybe from people that might be using the apprenticeships as employers. How
yeah, and as time goes on, we can obviously put some data together as well, common themes coming out, you know, common things that are not happening in assessments, and also that's another reason for the apprenticeship reform, is that endpoint assessment is supposed to be, you know, improvement focused, so that there's a 12-month life cycle on the assessment materials, you know, so there's a refresh every 12 months for at least 30% of the materials, and we can act on findings from endpoint assessment. And so it isn't supposed to be, right, there's your endpoint assessment, end of the story. It's about informing, improving, developing each job role, and, you know, working alongside all the providers. So yeah, we can do that next year. We could come back and do a reflection on last year.
Lovely, thanks very much. So thank you, Julie and Tracy, for a really informative and useful presentation. As you said, we'll be able to share the resources that you have available to you in addition to these slides through the web page. So thank you very, very much. We're now going to break for a short 10-minute comfort break, coming back at 5 to 11, when we'll be looking at new roles for psychology graduates, and we'll be starting that session with an introduction by Mike Burgess, who is the Workforce and Education Transformation Lead for Lancashire and South Cumbria, before we move into looking at the pilot with the team that have been devising and running it. So I'll invite you to step away from your computer, replenish your cups, have a comfort break, and we'll be back together here at 5 to 11. See you shortly.
Hello.
Hi, Mike. How are you doing?
Not so bad, thank you. For
Good to see you.
a wet Thursday morning.
Oh, no, it's a bit of a contrast to all the sunshine.
It has, and the temperature's dropped a lot as well.
Yeah.
Catherine's joined as well.
Hello.
Hi, Catherine.
Hello.
Lovely. Hi, Catherine.
Hello, Claire.
Well, we're the joys of thunder and lightning and hailstones. And then Trafford General, which isn't that far from me, got struck by lightning, which you
I
probably
think
saw in the news.
Got a couple of rumbles
Awesome.
yesterday. That was about it here. But it's raining and grey.
Right.
Miranda.
Hi, Miranda. Looks like
Hi.
everybody's back. So welcome everybody back following your comfort break. Hopefully you're now seated and ready for the second part of our New and Emerging Roles Forum. So we're delighted to welcome Mike Burgess from Health Education England to give us a brief overview of the context within which the new Roles for Psychology graduates, the TAPS pilot project, has developed. So following on from Mike, the team will then give us an overview of the pilot project, and also we'll have some time hopefully for questions at the end of the presentation. But we've also got at 25 to 12 our forum, our information exchange within the forum. So there'll be an opportunity to explore issues and questions that arise from this during that period too. So without further ado, I will hand over to Mike. Over to you, Mike. We'll turn our cameras off.
Thank you. Is somebody sharing the slides?
Yeah, I'll do my. I'll get them up now for you.
All right, thank you. So whilst we're doing that, I'm Mike Burgess. I'm the Workforce and Education Transformation Lead in Lancashire, South Cumbria. Prior to that, I've worked in workforce strategy and planning, OD leadership. So this was quite a nice presentation for me to write and share with you. And I was probably part of the initial concept for the TAPS program. But again, I've talked around finding innovative solutions quite generically and specifically, but I wanted sort of Gita and Miranda to focus on the detail about the program. So next slide, please. So again, the whole concept of the program, as does with any workforce innovation, predominantly starts with the planning and the people approach and the challenge that you're trying to solve. And obviously workforce planning is currently all over the news that we haven't got enough workforce, but have we ever had enough workforce? And the planners always get it wrong. But for me personally, and for Lancashire South Cumbria, we look at it through a number of different lenses, which helped us to articulate with the North West Coast Innovation Agency, with Lancashire and South Cumbria FT and other partners, the real need for this new role. So again, we take the basic broad concept of strategic planning and looking around the future thinking and that long term, that 5 years, 10 years. We know the lead times for education for graduates is 3 to 4 years, for medicals 7 years plus. So we need to think in some of those strategic timeframes. And I hope you've noticed HEE with Department of Health and Social Care and Arrange, we've just come out for a call for evidence and our 15-year framework to refresh that for health and care, if you look on the website. So again, we're thinking longer term now. What is the type of workforce we're going to need in 15 years time to help deliver that health and care? So we look at it strategically, and then we try and balance that around the workforce we've currently got, who we've got, the professions, are they qualified, non-qualified, admin, clerical, are they new roles, are they accredited, are they registered, are they blended, are they future, are they at school now, or are they just coming out, are we inclusive? So there's a whole raft of parameters that we need to think of regarding any new role that's implemented, and the new roles assessments that are undertaken cut across that broad spectrum. And then we need to sort of plan for that. How are we going to forecast? How are we going to model that? What are the analytics? How do people flow through systems? What's coming on the horizon? How do we move from that data to intelligence? We're looking a lot now at behavioural science, especially as we've gone through COVID, and how attitudes are changing and people are behaving and how they're responding and are being agile. And obviously we look at the evidence bases. Who's done this before? What's the qualitative research saying that can help us with our people approach and our planning? So as we speak, there's a team looking at the future demand for TAPS, working with the RAP team, who are now the Workforce Planning and Development Hub, looking across Lancashire, South Cumbria, Cheshire, Mersey and GM around demand, and how do we contribute to the 10,000 extra mental health practitioners that are needed nationally. And it was great to hear work about the apprenticeships. But even in Lancashire, South Cumbria, we've got a strategic apprenticeship group that spans the whole of the patch, looking at apprenticeships. But actually, do they really plan for what they really need across the systems? And the answer is now we're beginning to think around how many apprenticeships in what areas do we really need to widen participation and meet our supply. So next slide, please. So what, you know, why have we done this? And there's a couple of thematic things that start to come out, starting with the mental health 5-year forward view, you know, going back a while now, then the mental health long-term plans. And there were some key workforce challenges around the potential numbers that England and regionally and locally that they wanted to recruit into mental health expansion, and the money they keep saying is in the CCG baselines. You can debate that at your leisure, but actually, and that expansion cut across NHS, community and the independent sector. We're carrying so many high vacancies in the medical workforce, the clinical workforce and support workforce across the northwest coast, and the lack of traditional supply isn't huge. Even with greater investment, with clinical placement expansion monies and more money, you know, it hasn't expanded that supply to the levels that we would have anticipated. And in our patch, we had a very blunt review from Northumberland, Tyne and Wear about how our system operated. And yet we know that there's thousands of psychology graduates who want to join the NHS, and there's no real integrated career structure apart from them either starting as a healthcare assistant or coming in as another role and ping-ponging their way through to get to where they want to be over a number of years. Yeah. So again, that really drove our drive for innovation. And it's not just psychology graduates, so it's a range of other graduates who've done some sort of health related, but it isn't a clinical registered program, like health sciences, counselling, other types of therapy, who really want to access our system. And unfortunately, the NHS make it as difficult as possible for people to join with our job descriptions, our adverts, and saying you must have 75 years experience at this level. So we need to change, and TAPS was part of that change. Again, service redesign. We know through the mental health investment programs that have gone in, where the money's gone in, they have tried to recruit to a workforce to deliver this service and not being able to recruit. There's no supply. So actually we needed to start to think out of the box and differently. What we could recruit and train up with some clinical input to actually be able to offer a service and take pressure off the more senior clinical and medical profession in that key area. And I suppose one of the big catalysts that have helped us is that the integrated care systems are on a maturity journey. It is system first. There is a focus on place, and being at place with the integrated care partnerships and the multi-care partnerships allows us to work with the primary care networks in a place to be able to offer innovative local solutions that will work for us, work across the northwest coast. They may not necessarily work in other areas, but they're very bespoke to our workforce needs. Next, please. So these are my building blocks, and I always pull these out around where do you start, and actually how do you go about devising a new role. So we know we've got a huge vacancy problem, we know we've got a supply problem, we know we can't recruit people to meet expansion in specific services, and we know we've got an unmet need, especially through COVID, of the need for mental health and psychological well-being support and intervention at a low level and a medium level. But actually we start to look at what are the service plans saying from our organisations in our systems, and how does that then define the tasks that need to be completed, the roles who will deliver it, not necessarily the traditional roles, the competencies they would need and the capability they would need to be able to do that, and whether they worked in a service, a pathway, in an integrated team or a multidisciplinary team, and whether they came from primary care networks, providers, social care or PVON. We start to build up from the bottom that demand into our integrated care plans, our multi-care plans within the integrated care system. And we've sort of done this for the TAPs across the northwest coast, bearing in mind that there's national mental health plans that translate to regional, and obviously each ICS has to have its strategy. So actually it is bottom up, but it checks itself against top down. Next slide, please. So there was a few more questions we needed to ask on our journey, and I've dropped COVID in now. Obviously it wasn't even on our minds in 2017, but then there was a lot of other demands that came from a lot of other pressures in the system. But the COVID has really refocused the need for recovery and future pressures that generates around vaccination hesitancy, elective recovery, unmet need, delayed presentations, gaps in routine, people, you know, psychologically impact from the whole of COVID. So actually we know that demand is going through the roof, and we're seeing it now through primary care with the TAPS workforce we've got. Some other catalysts that are really helping us are some of the digital health innovations to improve patient care, allowing us to look after the worried well, but to look after people who are on waiting lists, who may be on that list a long time now before they actually get seen as we work through the 13 million, but conscious that there's still digital exclusion and there's positive and negative effect on inequalities around people having access to digital. As well as all this, people's perceptions and expectations are changing. I would say over the last 18 months how people have changed in terms of workforce, patients, students, carers, communities. So again, pre-COVID, there would have been a range of expectations that you would expect this, but now that has considerably changed, and we need a workforce that's agile and adaptable that can meet that need. And again, we need these innovative solutions. We need to get upstream of stuff. We do need new roles, and I know that there's a plethora of new roles. There's a range of roles in the psychological professions, but actually we need, if we haven't got a new role that can be adapted to meet a need, then we will have to have a new role, and that's what we've done with TAPS. Next slide, please. Has it changed? Oh, there we are. So in essence, for this, we discovered that mental health services represent the most significant growth area in the NHS, in parallel with primary care. Yeah, acute care support for long-term conditions and major trauma are not fully supported. The psychological impact of COVID is now being realised. Primary care support for PCN level for long-term conditions hasn't been fully supported, but it's getting there, and the commissioner and provider landscape has been a bit murky. So on the supply side, we know that we've got over 800 vacancies in mental health in the northwest coast, and we've made little progress to closing the gap. Many parts of the demand are not recognised in the workforce plan. It's hidden because it's in different sectors that are not necessarily at the forefront or in small suppliers. A significant potential workforce is being ignored by the system, i.e. graduates who could contribute, and sometimes the professional bodies are not working in together. And we know that the top 3 population health needs across Lancashire, South Cumbria are hypertension, depression and obesity, and the things with the highest prevalence are now an increasing prevalence is depression. So actually we really need a workforce that can innovatively meet this demand. Next slide, conscious of time. So what we've done is we've used the good old HEE STAR tool, and again this is a really simple mechanism to allow systems, pathways, teams, care areas to talk around, well, what have we got in terms of a supply? What's coming through in the future? How old are our supply? How much do they participate? Where are they? Are they in acute trust and in primary care? They allow you to get some of that evidence around, we haven't got a future supply, or we have but they're in the wrong place, or we have but they're not the right workforce. So it allows you to look at the supply. It allows you, well, out of that supply, what could be rapidly upskilled to meet these needs. And we went through a whole plethora of questions. Could we upskill somebody else to do this? But a lot of the roles are already in very predetermined specialist pathways to deliver specific things, and actually we needed something a bit more generic and a little bit more general that had a real core area to deliver wide across primary care and acute, but actually specialized where it needed to. So actually for us this didn't really exist, so we developed this new role. So we looked at the evidence and research from the scoping. There's some great papers that have built up the story that Gita and Miranda will say. We know there was a large non-clinical supply in psychology and other workforce. We know the evidence in the survey with HEI stakeholders and the psychology students that there was a real appetite to come into health. They didn't want to be a healthcare assistant and get some clinical experience. They wanted a course that gave it. And we know there's a lack of career structure. So actually, the story that Gita and Miranda will tell you is how we're trying to address what the students want, what the HEIs want, what the patients want, and what we want out of this innovative new role. And I suppose that cuts it. That's it. Any questions?
Thank you, Mike. Jeannie, is your question a quick one? Otherwise, we'll save it until the end. I don't know. Is it a quick clarification?
Yeah, I don't mind saying it to the end. It was just more specifically about what Mike's just been talking about, really.
Okay. Can we come back to it after the presentation, just so that we try and keep to schedule? And so now I will hand over to Gita. Thank you, Mike. It was really informative, lots of context. And now we're going to hear from Gita, Miranda and Mark as part of the team delivering the pilot.
So we seamlessly, thanks Claire. So hi everyone. So as our group of presenters, we hadn't actually seamlessly decided who was going to present the slides. So I'm happy to share my screen and move it on from there. So just to, I suppose, introduce myself. No, I need to do this the slideshow bit, and I can't seem to manage to sort of talk. And right, slideshow. From beginning, right, just swap. Yep, is that slide now sort of visible to all?
That's good.
Yeah.
Yeah, great, thanks. Okay, so very briefly, so I'm Gita Bhutani. I work in Lancashire and South Cumbria Trust, but I also co-chair the Psychological Professions Network in the Northwest with Claire. So it's really exciting actually to be able to give a presentation here today, and Claire can do all the chairing. So as Mike did a really, really helpful trailer, I will be very brief just in terms of sort of setting the scene. So, right, why are my slides not moving? Yep, there we go. So this project started in the North West Coast Academic Health Science Network, also known as the Innovation Agency, around about 2018-19, and we did some work around scope and the opportunities in psychological professions to improve workforce supply. And what we found with some of the work we did is that, you know, certainly up to 30% of psychology undergraduates would work in the NHS if a career was available to them. And many of you on this call will know that there's probably up to 200 applicants or more for every role like an assistant psychologist, and there isn't a very clear generic graduate entry point. So we've got a fragmented career pathway with silos, as Mike has said. So I think one of the things we were keen to do was just think about, well, could we do a program which was a generic program? It was a test of concept, and it was working with UCLan for the trainee associate psychological practitioners to be placed in NHS settings and undertake a postgraduate diploma associate psychological practitioner role. I'm just cantering through these. Right. And again, I think Mike's probably said quite a bit of this. These were the ambitions, you know, improving access, the COVID pandemic, current arrangements are complex, and I think looking at a sustainable workforce supply so that we have people who can just come into the NHS, maybe do a bit of training, and then they can actually take on roles across a range of specialties and a range of areas, and perhaps getting away from that kind of silo-based approach. So our pilot covers those areas. That's our geography. Our funding support was from Health Education England, and it's been hosted by the North West Coast Academic Health Science Network. So that's just me doing the trailer. Now I get to hand over to Miranda to tell you the bits that you really want to know, which is what is it, how's it work, and where's it all happening. So over to you, Miranda.
I'll try and meet that request, Gita. Okay, next slide. Oh, there we go. Perfect. So there's out of the 50 taps then, this slide shows where they are placed. There's 17 over in Cheshire and Merseyside, and if you look down on the left hand side of the screen you can see the teams where those taps are based. So it's from crisis teams all the way through to primary care and clinical health psychology settings. And then in Lancashire, South Cumbria, we have 33 taps placed with us. So 9 of them are in non-primary care network or non-PCN roles, so long-term conditions, occupational health, LD or CMHT settings. And then there's 24 in PCN roles. I should say I'm the clinical lead for the PCN TAP roles. And so 20 of those TAPs are based in primary care network. So sometimes that looks as though what that looks like is they may be based in one general practice setting, but some PCNs have decided to spread their TAP resource right across the PCN. So sometimes that's 3 or 4 practices, and in one setting it's actually 10 practices. So that TAP is split over the 10 practices. We've got 2 in INTs or integrated neighbourhood teams, and then 2 in council for voluntary services. So there really is kind of a wide scope of where the TAPs are based. So if you could just pop onto the next slide, please, Gita. So this is where the TAPs are in the GP and community settings. So this is the 24 in PCN settings. You can see they're spread across the ICP areas, and we wanted that. Initially, we approached people in CCGs to try and find expressions of interest of who wanted to work alongside a TAP and have a TAP within their service, and we wanted that spread right across the Lancashire and South Cumbria footprint, so right up kind of South Lakes all the way down to West Lancashire. You can see there where they're placed. Okay, next slide please. Okay, so just chat a little bit about what the TAPs, and obviously when they're not trainees anymore, they'll be referred to as apps. So what the apps actually do, and you can see themes really, and I guess it's based around what banding they are. So when they're training, when they're TAPs, they're at band 4, and when they're qualified, become apps, they're at band 5. So you can see they're working, I won't read through all that, but either working in a CMHT, for example, or within acute and specialist health services. You can see themes around them being able to support with assessments, doing co-facilitation of group therapeutic interventions, or specific interventions that around different areas, for example, sleep, CBT-based activity scheduling. You can see there supported by a psychological practitioner. Next slide, please. So I guess this is the area I know more about, because this is the where I'm more involved, but this is our service delivery model for the primary care TAPs. So we sit quite nicely underneath IAPT services secondary care, which is the triangle section at the top of this service delivery model. And so at PCN level, the two boxes below, we try and offer a service that we call universal offer and also targeted offer. We focus on mental health prevention and promotion. So from a universal angle, if you look at the bottom box there, you can see that the TAPs, they have 1 day a week where we ask them to go and link with their local community to increase resiliency, normalise mental health, try and prevent further deterioration and promote the idea that you've got to look after your emotional well-being, just like you have to look after your physical health, and people know that you need to do exercise or eat healthy. We want to help give the message that you've also got to look after your emotional well-being as well. So that fits with our universal offer. So the TAPs are doing things like linking with schools. They are doing talks with people. There's summer camps on at the minute for people who qualify for free school meals. So they're making links there. They link with local community groups, grassroots groups like Men's Sheds, Knit and Natter, Sparkle, lots of variety of names. They link with groups like that and go and give wellbeing talks. They link with local wellbeing hubs in councils and food banks. We've had TAPs stood on Fleetwood Market handing out leaflets around 5 ways to wellbeing, or putting leaflets about how to look after your mental health in food bank parcels. They've linked with partnership organisations like DWP, and where they've had employment focus groups and local businesses like supermarkets and things like that. And we've had a TAP recently go around on a vaccine bus, a COVID vaccine bus, and whilst people are waiting 15 minutes before they can leave after their vaccine, the TAP will go and have a discussion with them about if they're interested in learning more about how to look after the emotional well-being. So it really feels like that promotion to everybody. This is a message that everybody needs to understand. And then we've got a more targeted approach. So essentially that's the one-to-one work or the group work. And we focus, as I say, on mental health prevention and promotion. So that's at pre-caseness or mild difficulties. And generally in a GP setting, what that looks like is a GP or practice nurse may see someone and refer them into the TAP who sits within house, if you like, and offers that service in that GP setting. And we get lots of good feedback about that. I guess one thing we've learned is to adjust our language as mental health professionals to that of the world of physical healthcare professionals and ensure that the two really intertwine. I guess when, for example, if someone presents with feeling tired and they request that their GP takes their bloods to see if there's anything wrong or something like that, but the GP perhaps thinks actually they're okay, but it's more to do with low mood and lifestyle factors, then it's recognising, getting the GP to recognise people like that may well benefit from a brief intervention, focusing from a psychological approach with a TAP. So that's the second line there in the targeted approach. And then I guess there's also recognition that the TAPs are working with people who've got mild to moderate difficulties who will need referring into IAPT. As there's almost a bit of a bridging function whilst people are either referred in and on a waiting list, so there's some work to prevent further deterioration, or sometimes and often it's people who are first attending and they benefit a lot from psychoeducation around what they're fast beating heart to do with anxieties, for example. They may then decide that they don't want that referral to IAPT and that they've benefited enough from the brief intervention with a TAP. So that's our primary care or PCN service delivery model. You just pop onto the next slide, please, Gita. So I've spoken through quite a bit of this really. So what are the TAPs doing in primary care? So that hopefully the service delivery model helped explain what that is. But just briefly to say, so they do 3 days clinical work, so that's the one-to-one, that's the targeted offer, I guess. 1 day is that promotional, universal community focus, and then 1 day they are, whilst they're TAPs, they're studying still at UCLAM. Referral pathway in is anyone in general practice settings any clinician can refer into them. We have had some cases where some general practice settings wanted to try self-referral, and in some cases that's worked, and in other ways actually it was a bit unprotected for the TAP, and it feels better to go through a clinician. So we're still deciding the best way to do that and move forwards with that. So the TAPs offer, or the apps offer brief interventions, so they offer 4 sessions. And then a follow-up 4 to 6 weeks later, so that's the +1. They are, the work they do is underpinned by various psychological models. So they may use CBT skills, talking about thought challenging, for example, be informed by brief solution focused therapy, mindfulness-based skills. So they're not just CBT practitioners. We aim to keep them as a psychological practitioner who can draw on a range of skills dependent on client need and what the client is presenting with. We really encourage a system focus as well. It's an important other to attend. And I guess that's a recognition really that building resiliency comes through building relationships and relationships being healthy. And often it's a client's important other who's going to be helping them when they're worried late at night, for example, at home. We're obviously evaluating impact. So we do pre and post psychometric measures and again at follow-up. And we'll be reviewing all that data to look at the impact and show how the TAPs are adding value in these settings. And the TAPs are linking with population health management projects. So in various GP practices, dependent on local needs and assets, they often have a particular focus. I know Mike mentioned that the 3 areas in Lancashire, South Cumbria that are increasing in prevalence, I think you said obesity, Mike, didn't you? Depression and hypertension. So for example, in some GP settings, they may be focusing in those areas, and the TAP can really support a wellbeing offer alongside the physical health offer. So it's a real nice mix between physical and mental health in these settings. And I mentioned they use a Positive Steps group programme, which is essentially based around the 5 ways to wellbeing. OK, next slide, Gita. I think it might be my last. So just a quick note on supervision and supervisors then. So all the TAPs, of course, have supervision from a qualified psychological practitioner. We have a monthly North West Coast supervisory meeting where we support the supervisors, and essentially it depends how much supervision the TAP gets, depends on where they're sitting. So for example, there's some TAPs who are in IAPT services and they get group supervision, and then I think it's bi-weekly one-to-one supervision, and that's because they are in a team surrounded by psychological professionals, and there's lots of opportunities to ask questions about clients they're potentially working with. Whereas in the PCN settings, the TAPs aren't with a qualified psychologist, for example, so they have weekly one-to-one supervision and weekly group supervision to offer that additional support. And supervision is closely linked to the competency framework, which I'm sure Mark will chat a little bit more about, to ensure that the TAPs are meeting their competencies and thinking about their learning areas, and that links to supervision to help grow their learning development. OK, next slide. I think I'm going to pass over to Mark now. So Mark, I will pass over to you.
Yeah. OK, thanks. So sort of following on from Miranda, I'm going to talk a little bit about the entry requirements, the course structure, but around the competency areas. But also I'm going to try and add to sort of identifying the app practitioners and the TAP trainees in the context of other practitioners as well. So one of our first considerations was that we were not aiming to try and draw into the training the elite psychology graduates. We were looking to broaden it. We're looking at a sustainable workforce of practitioners who are seeing this as a sustainable career. And so we were not restricting ourselves to 2-1 and above. We are looking at trainees who have a psychology degree, but from a 2-2 and above level. And very much we think that this opens up the opportunity for a really great opportunity for a lot of our graduates across the country who have psychology degrees, who are passionate about working with people, but haven't necessarily identified themselves as being people who are going to go on to do the DCLIN. They range in terms of the amount of prior experience they've had. So we have in the first cohort of 50 trainees, we range in terms of people who are relatively recent graduates through to people who've actually been embedded and working within the NHS as assistant psychologists for a number of years. There is an expectation through the interview process that they can demonstrate work with communities and people, either in a voluntary setting or in a paid setting. Gita, could we move on to the next one, please? Thank you. So this gives you sort of an overview of the training structure through the first pilot year. So we've based the course around a large single module so it's a 120 credit module, postgraduate diploma level. And this involves 180 hours of delivery. And these are based around the competency areas which were taken from the job description that was created for this role. And we work mostly with workshops. We do have some more discrete lectures, but mostly we're working at a very interactive level. And of course, because of COVID, whilst we had an expectation right from the start that because of the wide geographical distribution of trainees, we would deliver quite a lot of the material online. In its first inception, delivery has been 100% so far online because of COVID restrictions and that sort of thing. So we have quite a dynamic, interactive model of delivery. We bring in quite a lot of specialists to deliver in particular areas. Now, the actual articulation of what the trainees are doing and what they're developing comes through a portfolio system that we use, which relies upon a competency record sheet as a definitive document where the training needs and the specific learning journey in an area of competence is agreed with the clinical supervisor within the service and is focused upon the application of that competency within that service context. And alongside that, through a review process, we, through the course tutor, working with the clinical supervisor, explore this training journey with the trainees, and we also get them to actually create a fairly substantial reflective document within the portfolio, which again articulates their journey through the process. In its first iteration that we are still in at the moment, we were front loaded with 2 weeks of core competency content, and so they spent the first week on the course online with us. Then we had a gap of a few weeks, and then we came back and had the second week, and then we've spread out the rest of the delivery throughout the year. We have, and I'll show you on a subsequent slide, actually revised this for the next year. And we're actually front loading to a greater extent. Next slide, please, Gita. So here's a range of the sort of the competency areas. And again, what I will say is that for the next iteration, what we've done is we've consolidated a number of competency areas. We had quite a large range of what I call meta competencies, and we've actually distilled this down into sort of 3 core areas now. But as you'll see here, there's a list of different areas that we cover, and this sort of maps onto what Miranda's been talking about. So if we could move on to the next slide, please. Here you can see the, what it should say is 2021 and 2022. I've obviously got a typo on this, but this shows you the evolution of the course. Now, it's fairly subtle in a lot of ways. So as I've said, we have actually increased the front loading of delivery. I think Miranda alluded to the fact that what we have is 1 day, which is ring fenced for the actual training delivery, and also for personal study per week. And this aligns with the 4 days a week actually in a clinical faced role. So you'll see that we have in total a slight increase in the number of total hours of delivery. And then we also have built into this model the hours for clinical supervision. Clinical supervision is delivered as a mix of individual one-to-one supervision blended with group supervision. And I think you probably appreciate, as Miranda's talked about, there's a large number of the primary care network trainees, and they may actually receive supervision in small groups of sort of 4 or 5 some of the time, and at other times they're having it one-to-one, and this applies across the different other services as well. Can we move on to the next slide, please? Okay, now this is quite a large diagram showing, as I said, we've tried to consolidate into 3 core competency areas, and I'll leave you to look at the individual sub-elements later on. But as you'll see, we have a breakdown into effective working within a clinical service stroke team. We have specialist clinical skills competence, and then we have wider professional practice competence, and those break down. The 3 subsequent slides actually basically take these one at a time now. So if we could move on to the next slide. There we go. And so here you can see that as a few examples of this, examples of things like clinical communication. For quite a few years now, we've been working with professional medical role play actors with our Masters in Applied Clinical Psychology, and we run workshops working with the trainees, where they role play, working with clients and this sort of thing. I think it's quite interesting to find, because as I said a little bit towards the start, we have quite a range of entry into the course, from people who've actually worked within clinical services quite a lot through to people who haven't worked very much. And it's very interesting. It's not just those who are very new to working with clients who really value this experience. Also, those with a number of years of working within services have valued this substantially, because they get a very high quality of role play experience with highly trained and highly specialized professionals, but you can explore things that you obviously can't explore within a real clinical context. Then we have one of the newer things we're bringing in is EMIS training as part of it, because we found that trainees who are not coming from an NHS background were quite nervous starting out in terms of learning EMIS and this sort of thing. So this is an example of one of the very new things which is going to be front loaded into the induction period. Could we move on to the next slide, please? So here we have specialist clinical skills, and here you see quite a wide range of things. I'll pick out just a couple of things here. So obviously we spend quite a lot of time looking at things like formulation. Because we have quite a wide range of different roles that people are fulfilling within their app services, we have, for instance, behavior change and COM-B. So Susan Michie's COM-B model we found to be very, very valuable tool in some of the services in particular, which is used very widely. And then if you look a little bit further down, we have a range of different therapeutic interventions that are more or less appropriate in terms of the different contexts. Now, I think it's important to say at this level, what we're doing a lot is introducing people to a number of these techniques. And it is certainly the case that some of the trainees, as part of their in-service specialist competency development, are supporting and applying and actually getting training in these techniques. And I think if you think in parallel to, let's say, a newly qualified clinical psychologist who will need to go and do specialist training in particular areas, these are examples of some of the things that the app practitioners will go on to become, to develop further training in and that sort of thing. And this is important, I think, in reflecting the adaptability of the app practitioner as a person who can have the wider sort of universal skills that are important at this level of practice, but then also gone to some very specialist training and specialist competency to meet the needs of their varying different services. Again, coming back to what Mike was talking about when he was identifying some of the key themes which are very important. And, you know, a new theme coming through is obviously post-COVID recovery, resilience, and those sort of things. If we could move on to the next slide. So the third area is the wider professional practice competence. And here you see some examples. So something that we are going to spend a lot more time front loading in the induction for the second cohort is even more emphasis on self-care and effective use of clinical supervision. I think we actually had quite a lot of input in terms of the effective use of clinical supervision, but we're building more of that in. We put a lot of emphasis on reflective practice. And so, again, this is another of the themes. And it's very important, I think, that this is important material, particularly when we think about the sustainability of the role and their ongoing development and their impact and effectiveness in the service. Next slide, please. Finally, I think, Gita, is this moving on to your area? I'm not quite sure.
I'm not entirely sure either, but I'm happy to do it if that helps.
Okay.
So I think just in terms of, I suppose, just to be really, really clear, the aim of the role is that they will train at a Gender for Change Band 4. Apologies for the interruptions from my computer. It just notices when the camera's on and off and tells me, and you, obviously. So they train at Band 4, qualify at Band 5, and I think the aim was to actually have a role that's consistent with other psychological professional roles, such as counselling and psychological wellbeing practitioners at entry points into the health service or publicly funded services. There are job descriptions available, and I think the other thing that is outstanding for this role, as well as a range of other roles, is that we need to think about career progression planning and a pathway into other training too. So I think we're sort of fairly short on time. This is kind of back to you, Mark.
Yes,
so
sorry.
I don't know if you want to very quickly canter through this.
There are these two diagrams. There's the one on this page. I think you probably, it is.
I'll keep going.
Yeah, sorry. This is an animated diagram, and unfortunately, it's currently set to being clicked in. This is a diagram which is trying to articulate an answer to the question we get quite often: is what is an app and how are they different from different roles? So. In this representation, the inner circle represents a number of different roles. So obviously we've got the app practitioner, we've got high-level roles in psychological therapists, counsellors at band sort of 7+, etc., clinical psychologists 7+, and we also have support workers, we have assistant psychologists, and we have IAPT and other similar roles. And I think the important, interesting distinctions are things like, obviously, some of these roles actually have dedicated training associated with them. So obviously IAPT and the TAP training and specialist counselling training, and obviously the DCLIN are all defined trainings. Whereas also we have practitioners such as the assistant psychologists who have a fairly ad hoc role, so what your contribution is will depend upon what role you've been employed into, and the amount or degree of training you receive may be dependent upon the perceptions of the need to train you within the role you've been employed into, and similarly for support workers. Then maybe distinctions between, let's say, the IAPT practitioner and the psychological therapist, as opposed to the app practitioner and the clinical psychologist, is that the roles within the app role and the DCLIN are much broader training, allowing the person to develop specialization within their role, and the core training offers a much broader footprint of training to allow them to operate in these different sort of settings and then develop the specialist focus within their role. Next one, please. And this diagram tries to achieve a similar sort of approach, but here we're looking at people operating roughly at the same sort of level and introducing these sort of distinctions. So we've got IAP practitioners, app practitioners, assistant psychologists, mental health practitioners, and also psychological and health coaches. And so I won't go into detail because I'm mindful of time, but you should be able to see the distinctions in terms of the types of training they have and the types of roles they fulfill. Next one, please.
Okay, I think this one's back over to me, if I can. Right. Okay, so I think this is just our final slide, really, just in terms of trying to just highlight that, you know, pretty much going back to where